Alright, so I'll just briefly talk about AC joint injuries, which are very, very common in footy. So we'll just go through what the AC joint actually is. So it's the joint where it attaches the shoulder blade to the collarbone. So basically, here. So if you just come across like the spine, the scapula comes across, and if you look at the clavicle as well, sort of just where that point joins up, that's your AC joint. So that's this is soft standard sort of injury, but when you do like more of a severe sort of injury, you can also damage the ligaments from the coracoid process, which is just that little bony bit in the front of the shoulder there. So there's a couple of ligaments that come from there to the collarbone, and from there to the acromion as well. So depending on the grades of injury, those they can be affected as well. But typically they'll present when someone's been hit in the shoulder quite hard. They sort of they sort of struggle to be able to swing their arm through and struggle to be able to run. So when they come off, so they're quite tender. And they pretty much pinpoint, so they're really quite tender over the tip of the shoulder. And then when you try to assess how much movement they've got, they really struggle to actually get their arm quite above shoulder height and that sort of thing. And with that as well, I guess it makes it really hard for them to pop there. Oh yeah, there you go. Yeah. So these are those ligaments. So that's the AC joint there. That's the coracoid process there. So that's all those ligaments that I was talking about. Yeah. So just with the lack of range of motion as well, they might struggle to get their jumper off as well. So half the time you need to help them to pop the jumper off. And they probably need to sort of bend them over and sort of have their arms sort of dangling down, so they don't actually have to lift their arm up to get the jumper off. And I guess they always struggle to sort of push off and that sort of thing as well. And when it's really quite severe, as I said before, they'll really struggle to run. So that's like a bit of an indicator of when they can sort of return to play and return to train and that sort of thing. They're really quite sore, and they can't run or they can't really train and that sort of thing either. So. As I said before, like they can be graded, like basically 1, 2, and 3, just like most sort of joint sort of sprains. So grade 1s are your sort of minor sort of ones, and grade 2s are the ones where you start to see a bit of step deformity. So basically, Adrian doesn't have one, but basically you can see just a nice drop basically in the shoulder. So I guess for the more severe ones where they really struggle to move, that's something you might want to basically like sling them and make them quite comfortable so they don't actually have to carry the weight of their shoulder. But what I like to do as well, just like doing even just a normal sort of AC joint type taping, where you're sort of putting a tape across the arm, one across the shoulder as well, and sort of just coming up in it tends to do like 3 sort of strips. So one across the front, across the middle, and across the back, just all covering the AC joint as well. Just helps it support the shoulder, so it's not just hanging and sort of dangling and irritating the joint. So
when we see ones with a bad step deformity, we'll actually take them down for the first few weeks, won't we? To try and keep the collarbone down on top of the acromion. So it depends on their skin, but you can keep it up for about 2 weeks and just make sure that it's held down nice and firm, and then other tapings for comfort, isn't it?
Yeah. Well, yeah, if you're going to have it on for that long as well, always have a hyperfix underneath as well. Don't directly put that, just that rigid tape on top, otherwise you probably would get a few skin reactions. So I guess in terms of what we do, is we're always going to try to re-establish the range of motion and try to gradually strengthen up through the shoulder as well. And I guess advise if it is like a shoulder, like an AC joint injury, like basically just how to do that sort of taping again as well. So, but basically, I tend to just do a few simple sort of tests to try to figure out if it actually is an AC joint type injury. And basically, I always just do a general range of motion test to see how much movement they've got. Classically, with AC joints, they don't like their arm going across, and just getting that pinchiness sort of feeling across the shoulder. So just get just to bring that across, and sometimes just sort of like just push into that as well, and see if they get that reduces that pain. Again, just finding that AC joint and directly just touching touching over it. When they're freshly done, they don't really like anyone, even just like light pressure, they really dislike that. And another test I like to do is just a simple push-up test. So similar to like before, I was saying, they just don't like to push off and sort of, just don't like to push up the plane and that sort of thing. So if they can't do a push-up with strength and without pain, I'll pretty much might get them back playing again.
So these are your less severe ones you're probably trying to work out whether it's a minor AC they can keep going. There are a couple of sideline tests that's probably worthwhile just going through and just trying to work out whether you can keep going. That's what you sort of do in Swedish.
Exactly. And then if they pass all those sort of tests and can actually get a bit of strength, we can just take them up. And it sort of depends on the player as well. Some players are soups and they really want to play on, but otherwise some of them quite tough, and if they can handle it and put a bit of taping on, again, like a grand final sort of thing, just take them up and see how they go. So,
should you do surgery on the whole wall?
There's not really any evidence to suggest that you do surgery for the grade 3 ones where there's a massive gap really, but I have seen one that got surgically done, and it still took them ages to get them back anyway really. So it's just one of those ones we send them off to an orthopaedic surgeon, get an opinion, obviously from us and from them.
But once it's stretched, is it ever going to be supportive enough to actually hold it in?
It will always look weird, but yes, it will be functional.
It will scar up.
The evidence says that it's no different 6 to 12 months down the track if you do surgery or not compared to surgery. It depends on which surgeon you see, whether you get surgery or not, to be really frankly honest with you. So, I saw one today that was a week post-op and they'd done a Lars ligament transfer like you're doing like they're doing in these, so a false ligament over the top of it. So there's all sorts of weird, wonderful, I've never seen one before by the way, but there's all sorts of weird, wonderful things out there that these surgeons do. But with this particular thing, I've got 2 athletes that I can think of now that have played for the last 10 years that still, you can tell, like there's a massive step forward if they took their shoulder, their shirt off. They don't get any pain, full range of motion, functional, can play, fine. So, again, and there's limited evidence, there's a little bit of evidence to say you can get back slightly quicker if you have surgery. That's what I'll do with the AFL footballers most of the time. So, but again, it's only the really severe ones we're talking about now, the ones that are really sticking up that they hardly got any range with. So,
fair to say it's super important. It's important.
Correct. It's super important early on. You try and get as much knitting and scar tissue forming as you can. Yes, it's not going to look fine, but functionally it's going to work okay. And that's been my experience with it. And that's what the research says on AC joints as well. So.
Yeah, so basically with the, just a bit of treatment, I guess you can do for the AC joint, for the minor ones anyway, not like those bad ones we're talking about with Tim. So I'll just get Adelaide to lay these back, please. So I tend to release a lot through the pec, through the pec major, which sort of comes across and inserts at the front of the shoulder here. So pec minor, which lays underneath that as well, which attaches to the coronary process I was talking about before. I tend to do a bit of soft tissue work through there. So again, just a bit of sorbet cream, just going across the muscle belly itself. You can find a few trigger points and that sort of thing as well. Always just do a bit of holding and just like what Dave was saying, just like about 30 seconds and wait for it to release. So you can do that sort of simple stuff through the front, and then I guess if you flip them over, we're just doing a bit of work through there, upper traps and basically just through the back of the shoulder as well. Again, pretty much the same sort of techniques as we were using before. We're just going along the line of the muscle really. So again, you can just use your fingertips, or you can use your thumbs, just to reduce the spasm around the shoulder.
When you've done your AC joint, you're guaranteed to have neck pain, tension. They'll grab hold and hang on all the time. So sometimes their worst symptoms actually their neck and the muscles that come down. So do you do any cross friction on the ligament?
I tend not to.
Yep.
With any sort of thing, there's always different techniques and different strategies.
I'm old school. I tend, when I know someone's ligament's trying to heal up, I'll go cross friction over it to try and improve the blood flow to it. And there was an old theory about when collagen fibres laid down, which is scar tissue, it's laid down all hickory-pickory, all different directions. And cross friction massage and tensile pressure on it helps to realign the collagen fibres into more parallel lines for a stronger heel. That's fairly old school. Tim still here? Is that still sort of?
I tend to do it. I don't know whether there's too much strong evidence.
We haven't heard any strong evidence lately, but certainly...
I tend to do it because I'm a bit old school as well.
Yeah. Yeah, we look old, don't we? So yeah, cross-friction massage, which I was explaining before, is going across the fibres or something, okay? So at the very least, it improves blood flow and blood supply to the area it's trying to heal up. So you don't do that in that first acute phase. This is when, 1 to 2 weeks down the track, okay, and you're trying to make sure they get as good a healing as they can. So for the first 6 weeks, that ligament's slowly tightening up. So that step deformity will improve over the first 6 weeks, and we want to encourage everything we can to make sure that happens, so have as good a heal as possible.
So you're talking about that?
Yeah, so if you show on the shoulder model, Donny, so it's really big one. So you're just going straight across the end of the collarbone and follow your way around. That's it. So you're going to find the end of the bony bit and just work across there. Yeah, and they can do that themselves. You can teach them to do that every day themselves. Work in there just with cream. Yep. Good.